start formally. What are the functions of liver?
It has function related the coagulation factors which it prepared. All the coagulation factors have been prepared by the liver except the factor 8 and 1 Willebrand factor. Also, pseudocholinesterase is also synthesized in the liver. If we divide the functions into the metabolic and the nutrient metabolism function of the liver,
that is the one which you should be starting with rather than starting with coagulation.
Yes,
okay, synthetic
sorry.
function,
I have to compile my
detoxifying
answer.
function, yes, okay.
Yes, and the synthetic function, yes, detoxification function, the metabolism function, and also the secretion of bile, which it does. Now coming towards and also the immune function which it has. So coming towards the synthetic function, it synthesizes the clotting factors, all the clotting factors except the factor 8. It also synthesizes the plasma cholinesterase and also albumin alpha 1 antitrypsin and proteases. And now coming towards the secretion and creation of bile also is the function of liver. Now coming towards the nutrition and nutrient metabolism, which are the amino acids, the proteins and the lipids, I guess. And now coming towards the immune function, liver also has the Kupffer cells which help in the immune function.
Okay. So what about in general concept people say that liver synthesize blood. Is it true? Does liver synthesize blood?
In fetus, I guess yes. In fetus, it synthesizes majority of the blood, and now in adults, the bone marrow is the one which synthesizes blood. If I am not wrong.
Yes, because in the layman concept, people say that liver is synthesizing the blood, right? Okay, so just a second. So now we will be coming to our topic, which we are supposed to discuss today. Just a second. Okay. So Tayyaba, I will just start with Atiq bhai. This scenario, and then you will be on backup. You will just add on. So Atiq bhai, as I told you this scenario, I sent you this scenario in the morning as well, that there is a middle-aged patient. Can you hear Dr. Atiq? Dr. Atiq, can you hear us?
Ji sir, ji sir.
Yes, okay. So we have a middle-aged patient, which is known case of end-stage liver disease, okay? And this patient is presented in emergency with acute abdomen, and there is a provisional diagnosis of obstructed inguinal hernia. So surgeon wants to proceed. What will be your initial, what optimization you can get after discussion with the surgeon, and how much what is difference between obstructed inguinal hernia and incarcerated gangrenous inguinal hernia?
Sir, we will have to, first of all, we will optimize the patient from surgical aspect, as well as from the anesthesia aspect, and as well as from the patient comorbids as well. And the surgery is, so the surgery, first of all, the surgery it is an emergency procedure.
I will repeat my question. The first part of question which I asked to you, what is difference between gangrenous and obstructed?
Sir, the gangrenous means
like gangrenous or incarcerated versus obstructed. What's more serious, and why?
Sir, the obstructive, sir.
No,
because it can already the gangrene had already done, but
no. First of all, obstruction will occur and if you don't relieve the obstruction, then gangrene will occur. Okay. So incarcerated or gangrenous is the next step of obstruction. The hernias are reducible, then it became irreducible, then it became obstructed, and then it became gangrenous. Okay. So gangrene is the last stage. So gangrene, it's like emergence. Okay. Because as much you will delay, there will more and more chances of patient going in sepsis. Okay, so this is
both are emergent, sir. Both are emergent procedure, but the gangrenous is the more important one as far as you concerned, sir. Sir, we first of all, sir, I will come up to the surgical side. Since it is an emergent procedure, I would say, so we would have to optimize from the surgical point of view. We will discuss with the surgeon, and we will prepare the and we will ask how much time we will take, and if the patient is non-NPO, we will prepare the patient as a risk of respiration, sir. And second one, since this patient is having end-stage renal disease, so the concerns are
end-stage liver disease.
End-stage liver disease. End-stage liver disease,
not renal disease. Renal disease was yesterday.
Yes, okay. So, in the liver disease, we are concerned of the since it involves all the systems. So the multisystemic dysfunction will occur, like encephalopathy, hepatodynamic circulation, and the pulmonary weak mismatch, and Hepatoreal Syndrome, and varices, and the most important is the coagulopathy with the endocrine dysfunction like hypoglycemia and lactic acidosis. As far as the disease itself is concerned, it can cause due to viral drugs, and due to some other, and it will have the patient have altered pharmacological, physiological state in the patient. And sir, as far as anesthesia is concerned, we will divide it in. So this is a very high risk patient, so we will divide in a child box score system. And sir, we have to optimize for the correction of coagulopathy, and for correction of hypovolemia, since the patient can be hypovolemic, and we will optimize the patient with the respiratory mechanics. We will optimize the patient with the fluid shift and blood loss because of the multiple function that is being synthesized in the liver. And sir, we will also optimize the patient with the patient already taking the drugs, hepatically metabolized drugs, I would say. And sir, we will also take the universal precaution of the
so, if I just try to if someone can just tell me in summarized way, like you have told a number of things. Okay, so
sir, one point I forgot that in the surgical procedure, we will ask for the surgeon whether he will go open or whether he will go with laparoscopic. Then there would be laparoscopic concern as well, sir.
Okay, so actually, if you because if some if I just ask you what are the challenges, so challenge related to the end organ damage because of end stage liver disease in the other systems. Okay, so the patient, you have to stratify. You said divided. It's not divided. It's classified. It's risk stratification on the base of Child-Pugh score. Okay, so on the basis of Child-Pugh, you will say how much severity of liver damage it is, and severity of effect of liver failure the patient has. And your target is not to, if the patient is in Child-Pugh C, you will try to push it in B. If it is in B, you will try to put it in A. and not get it worsen. So this is your aim. Okay, so that aim you will be achieving in the form of correction of coagulopathy, giving some fluid, drainage of ascites. Okay, so these are the things which you can do, but in this patient you will have very limited time. So only few things you can do is that you can just have an ABGs, you can start fluid management, and you will discuss with the surgeon that what's their plan, whether, as you told, whether they are doing it open or laparoscopically, and so the concerns will be related to that. And as much as the sites of orthosystemic shunts are involved, that much will be the chances of decompensation. Okay, patient can bleed, upper GI bleed, lower GI bleed. Patient can go in encephalopathy. Patient can have the cardiovascular involvement, the respiratory involvement. So you did not mention anything about post-operative arrangement of ICU. You did not mention anything about the arrangement of blood and blood products. Okay, so like these will be the challenges. Like you, if I go back again, if someone asks you that what are the concerns in a patient with end-stage liver disease, so you will be answering that my concerns will be according to, first of all, stratification of the severity of the disease the patient has, because it can vary significantly. It can be from a cirrhotic liver to the patient which is almost having encephalopathy. So you will be stratifying first, and then your aim will be to not to get the patient decompensated. You will arrange HDU, you will arrange blood and blood products. You will try to, if you want to reverse coagulopathy, yes, if you have the facility to do stat INR, or if you have the facility to do immediately hemoQ, you can get the blood results as well immediately. Okay, but at least you can do ABGs to see the status of the patient at that time, and then whatever optimization, any electrolyte imbalance. Zishan, would you like to tell which electrolyte imbalance will the patient have in this state?
Sir, one point left there, sir. Can I add this?
Yes, please.
Sir, first of all, sir, we have to arrange the blood before going to the operation, and sir, we should be, if the facility available with us is having, then especially we should concerned about the if the patient is already the patient is on the blood products.
I think, bhai, tell something new. I have revised this a few seconds ago. Anything else?
Sir, anemia.
Okay, anemia, patient can be anemic. Yes, fine, absolutely fine. Okay. So what was the question? Actually, I forgot the question, Zishan. What question did I ask?
The electrolyte imbalance in
yes,
liver
which
disease.
which electrolyte imbalance will be there in this patient?
Sir, I'm not sure, but if I take a guess, so it would be hypoglycemia, hyponatremia, and hypokalemia.
Hypokalemia. Okay, fine.
Glycemia and hyponatremia.
What about hypernatremia?
Both hyponatremia would be there.
Can occur. Okay. According to what?
The fluid status of the patient, basically.
Okay. Why there is okay, Rabia, since you have told that, why there will be hypernatremia?
Sir, because of hepatorenal syndrome.
No.
And sir, because of
the hypoalbuminemia, sir, hypoalbuminemia.
No, hypoalbuminemia has nothing to do. Yes, Tayyeba?
Sir, intravascular.
I guess this is because of the first we start with the portal hypertension, and there is ascites, and there is hypernatremia, right? When there is decreased effective intravascular volume, there is activation of RAS, which is the renal angiotensin aldosterone system. Then this causes the
salt and water retention. Salt and water
Yes.
retention.
Then this causes hyponatremia. I guess this is the mechanism. If I'm not wrong.
Even if there is hyponatremia, the total body sodium will not be decreased. Okay, because there will be retention of water as well. Yes, Dr. Adnan, what you want to add? Dr. Adnan Alam.
Yes, sir. So, yes, I wanted to say the same thing, that because the kidneys detect the hypoperfusion, so they will secrete aldosterone, they
Yes.
will retain sodium. Yes, sir.
Yes, the same thing which Tayyaba told. Okay, so
Yes,
the problems will be related to electrolyte imbalance, problems related to fluid balance, and you have to mention specifically because there is portal hypertension. So the portosystemic shunts will be the site of bleeding. Okay, there will be some features in the abdomen. What will be that called?
So the esophageal varices.
No, in the abdomen.
Spider nevi.
Caput medusae and spider nevi. Okay, and this one in the esophageal varices or rectal bleeding. Okay, so these bleeding can occur. So this is one concern. Sites of portosystemic shunts. This is one thing. The other thing is because of synthetic function. If you divide it, it will be easier for you. What are the other problems, Rabia, because of overload? Overload state, what are the problems related to overload state?
Sir, hyperdynamic circulation
Yes.
and
Low
also
SVR. Low SVR.
low SVR. Yes, sir.
Low SVR, cardiac, there can be
Would be
cardiac decompensation, cardiomyopathy. Okay, so this is
Yes, sir.
because
Cirrhotic cardiomyopathy.
yes, cirrhotic cardiomyopathy like failure, overload state. This state is overload. Okay, so this is one thing. And what will be the problems related to synthetic problems in liver failure? What will be those?
Coagulopathy.
Coagulopathy due to
Coagulopathy.
disease, formation of the clotting factors, and also hypoglycemia due to decrease glycogen.
Okay, that is okay, fine. This is related to insulin hyperactivity as well.
Yes, sir, because insulin is not metabolized and stores are less. So,
okay, so this is one thing, but synthetic function, you have to tell coagulopathy and hypoalbuminemia. Okay, and
yes, sir.
so what will be the effect? The drugs which are bound to proteins will be free drugs,
And there would be toxicity of those drugs or prolonged effect.
yes. So Tayyaba, what will be the problems related to metabolic problems, like impaired metabolic problem? What will be a clinical effect, or what will be the challenges?
Sir, regarding metabolism, the electrolyte, you're talking about the electrolyte imbalance.
Metabolic problems, like whatever you can say. Metabolic is all metabolism, the metabolic function of liver. What will be the effects because of metabolic dysfunction of liver? All metabolism, Tayyaba. All.
So the drugs cannot be metabolized because
Sir, can I tell?
phase-
Sir?
No, just a second. Just a
phase
second.
1.
No, all the drug metabolism, all the
Yes.
protein metabolism, fat molecule metabolism, lipid metabolism, everything will be decreased. Am I right?
Yes, sir.
So coagulation factor. Then what else? What is the involvement in the in RAS? What is the involvement of liver in RAS? This renin-angiotensin system. What is secreted from the liver?
Sir,
Angiotensin.
Just what did you say, Tayyaba? Angio. What part of RAS is from liver? Yes, Rabia, you tell.
Sir, angiotensin.
No, angiotensin.
Angiotensin 2
No.
is
No. I knew that.
one is secreted in from the liver and it is converted into 2 in the lungs, and from there it is
No. I'm not talking about lungs. I'm talking about liver. So angiotensinogen, from where it is
Yes, sir.
released?
Sir, from liver.
Okay. So angiotensinogen is converted into angiotensin 1 by,
Angiotensin converting enzyme.
no, that is for from 1 to 2.
So renin converts angiotensinogen to angiotensin 1, then
Yes,
angiotensin converting
yes.
enzyme converts angiotensin 1 to angiotensinogen 2.
Yes. Okay. So this
Okay,
is the answer. And what about vitamin D? What is the involvement of vitamin D?
Vitamin D.
Sir, vitamin D is from renal and sir from liver as well, both.
I'm talking at the moment, we are just having a cross-section practice of the problems related to liver. So be specific. What is the involvement in the vitamin D metabolism in liver? What happens in liver?
If I'm not wrong, this is converted into the active form,
Active
125
form.
dihydroxycholecalciferol.
Yes, D3. Okay. So if it is liver is not functioning, then this is also creating this problem. Okay?
Hypocalcemia.
Hypocalcemia. So this is another problem.
Sir, all fat soluble vitamins are created in this. Fat soluble vitamins are synthesized in liver, sir.
What are those vitamins?
Vitamin A, vitamin D, vitamin E, vitamin K.
Yes. Okay. And what are the vitamin K dependent coagulation factors?
2, 7, 9, 10.
And they are checked by
PT.
PT or INR?
PT and INR both, sir.
No,
INR,
INR.
by specifically
INR.
by INR.
By specifically
And
by
protein
INR.
C. Yes, protein C and protein S are also vitamin K dependent.
Yes. Okay. So this is just a revision of the liver functions. If you can read anywhere, if do anyone know about this liver zones, different liver zones? What is portal triad? This question can be asked in the long case. Okay. I think we will discuss this because I think I'm going beyond the time. We are covering the clinical aspects in a quick way. Apology for going in a little more detail, but why I'm just doing this practice, because what is the, okay, just tell me one thing. No, don't forget about what are the zones. What is related to the zones of the lung, zones of the liver?
For detoxification of the
opinion,
drugs, sir. Detoxification purposes, sir.
Detoxification purposes or what? It is
Sir,
because of ischemia.
sir, drug and oxygen both, sir.
Yes, Tayyaba, what were you saying?
in my concept, this is the ischemia, which you have rightly said that the zone 1, 2, and 3 in acute, whenever ischemia happens, the zone 1 is, I guess, the one which is disturbed the most in acute toxicity or the acute liver failure, if I am not wrong.
I think zones 3, because zone 3 is in the periphery.
It is zone 3, sir.
Okay. Zone 1 is most blood rich.
Yes, sir. Okay. It's a zone 3, right?
If someone, because if they are not going in details, but still they can ask you this question, at least if you will tell that zones of the hepatic zones are telling this thing. And the other is a portal triad, which is combination of hepatic artery, vein, and bile duct, and it is actually functional unit of the cell, of the liver. Okay. So this is the basics they can ask you. And how much is the blood supply of liver?
There are almost
25%
1500
of
ml
cardiac output.
5% of
This is
20-25.
1500 ml
20%
of the
for the
total
cardiac
cardiac
output.
output.
And what different kinds of this one liver blood flow?
25% from the
There are
total vein and 25% from the hepatic artery.
No, 50%.
Sir, oxygen supply is 50%, but blood supply is 25-75% ratio.
30. Okay, fine. I did not listen properly, Atik bhai. So oxygenation is from 50-50. That's what that's why I abruptly say no. Okay. So oxygenation is like that. Okay. So, okay, coming back to the clinical aspects again, the reason for telling this thing was not to forget the functions of liver, because all these functions you have to mention when you are telling the clinical effects. Okay. So it will be like that. Just a second. Okay, so whenever they are asking you what are the concerns, again, Atik bhai, please again remember one thing: try to be concise. Okay, try to cover the words which try to use the words which cover all the aspects. Okay, so you have to arrange whatever, you have to optimize whatever, and don't repeat again. You talked about surgeon 2 or 3 times, so that was not correct. Okay, you tell it one time and tell whatever is related to the surgery. Laparoscopic versus open, how much time, what are they expecting, and how are you evaluating the severity of the condition, because that gangrene is not related directly to the liver dysfunction. So liver dysfunction is one thing. Any comorbidities which are created because of liver dysfunction is other thing, and the problems related to inguinal hernia obstruction and causing the history will be very important. That how much is the history, how much duration history. If this patient is having a intestinal obstruction, his patient is not taking anything and vomiting, then everything will be exaggerated. Okay, so dehydration will be one problem, bleeding will be one problem, aspiration risk will be one problem, decompensated liver disease will be one problem, and further deterioration and going in encephalopathy is the other problem. So these are the things which these are the words which will summarize everything: coagulopathy, hypoalbuminemia, overload, or all the things related to hyperdynamic circulation and ascites. Okay, and like the things related to the surgical technique which they are using. If it is laparoscopic, the concerns related to laparoscopy, and actually laparoscopic surgery in this patient will have quite significant effects if the patient is already having heart failure. Okay, and if they are doing it open, then pain will be a problem. And very critical step in addition to the initial induction and maintenance will be the time when they are opening the abdomen, because if the patient has ascites, you have to replace fluid before they open it, because at that time patient can collapse. Certain tamponade effect will be finished, there will be redistribution of fluid, and patient can have severe hypovolemia, relative hypovolemia at that time. Okay, so these are the things which you should. So now coming back, because I'm trying to make you understand so that you don't miss anything, then answer will be very easy. Okay, because if you know what are the important points, then you will not forget anything. So now coming back, preoperatively, again, ABGs, a start of fluid, lactate, and any correctable coagulopathy which you can do at that time. Okay, so this is if this is for any other surgery, you can say that if you are doing the ascitic tap, this will relieve the obstruct respiratory functions and it will improve the post-operative outcome. If it were not inguinal hernia surgery, some other surgery. In this surgery, when they will open the abdomen in by any way, that ascites will already be drained. Okay. So that effect will be in a different way in this case. But in any other surgery other than this surgery, if they ask you, you can tell that immediately if there is time, if the patient has ascites and if you drain it, then it will have a good effect on your post-operative outcome. Okay. And what else you can use to correct the coagulopathy? Atik bhai, what are the options which you have? Immediately correction by FFPs or what?
Sir, factor 8.
No, factor 8, from where factor 8 came? Prothrombin complex concentrate.
Prothrombin complex concentrate, sir. I was telling.
Okay, FFPs or prothrombin complex concentrate. This will be very quick. You can say no.
Sir,
yes.
And also, sir, if the procedure is elective, we can also use vitamin K as well, sir.
Vitamin K will, how much time vitamin K will take?
36 hours.
Yes. Will you give IV or intramuscular?
We can give both.
Intramuscular injection should be given in patients with liver dysfunction?
No, sir.
No.
फंस गए हैं कि नहीं? Stuck or not?
Stuck.
Okay, thank you. So please try vitamin K only in specialized scenario, not in this. Okay, your answer was correct, but use it when it is appropriate. Okay, so because examiner will catch you. Okay, so these are the things which you will be doing. Then now we will come to the different steps. What monitoring will be needed? Will you go for central line?
Apart from standard 1, standard 2, we would use A line, CV line, and also
Okay.
if
Very good. CV line will you take in a patient with coagulopathy?
So we can take with
what will be the indication in this case, for example, which will be the compelling indications to use CVP?
Sir, for first of all, fluid management.
Fluid management can be, fluid management is not needed by CVP. It's not the prime reason. You are right, it can be used, but it is not because fluid status is better judged with the arterial line in this scenario. Yeah. Because if there is abdomen is full, venous pressure is already, will the CVP will be correct?
Yes.
So the only indication for central line might be the use of vasopressors.
Thank you very much. Chatta Saab, you have won the battle. Okay. So this is the compelling indication. If this patient is needing vasopressors, then you need central line, because central line will not be a simple procedure in this patient. You should be using ultrasound. You should not be using subclavian approach. There is risk of bleeding. There can be hematoma. Okay, mind it. So like CVP straight away, you will, even if you want to say, at least mention with the same without finishing the sentence, you say CVP if indicated, because there is risk of hematoma if you are using ultrasound. Okay. So any poke in any needle introduced in the body will not be safe, because it can create any problem. So arterial line will give you a better fluid status. You can follow the pulse volume variation plus pulse pressure variation. Okay, and then you can use someone just wrote in the message T can be option or no?
No, sir.
Why?
T should not be used.
Yes.
Because of a
T, if you want to kill the patient without any genuine reason, you put T and patient will have variceal bleed, and thank you very much. Okay. So unless you rule out esophageal varices, which are prone to bleed, you will tea will not be a very good choice. Okay, so everything, whatever you are using, you should have a reason, and you can say anything, but you should be knowing the backfire. So better, rather than examiner making a face, asking you a question, and then you are trying to fill the gap, rather than that, you don't let the examiner say anything. Okay, this will have this problem, this will have this problem. So CVP only if you are needing vasopressor, because CVP will have more risk than benefits. So because the fast fluids you can give with the peripheral to, big gauge cannulas, and fluid management you can monitor through CVP, sorry, through arterial line, and predictors like fluid status, clinical status of the patient, and the urine output. Okay.
Yes.
So this is other thing. Aspiration risk will be there. You know everything. I don't need to tell you this. There will be risk of aspiration. There will be so you have to outweigh risk versus benefit, and you can, because if there is hemodynamic instability, you can take arterial line and you can give titrated doses, modified rapid sequence induction, as Tayyaba I told you as well. Okay, so the same technique you can use if you have good. Can you use rocuronium or modified rapid sequence induction?
Yes, sir. If Sugammadex is available, we can use rocuronium.
Okay. And another thing is that succinylcholium, will there be any problem?
Yes, because of the
Potassium would be-
pseudocholinesterase is being synthesized by the liver,
Okay.
and this can be a problem, but theoretically this is a problem, but not seen as much. So you can use succinylcholium by weighing the
Succinylcholium
risk
is not
versus benefit as
contraindicated.
well.
Succinylcholium
Yes,
is
this
not
is
a
not
contraindicated. You
Yes.
can use succinylcholium because usually here there is no hyperkalemia, rather there is hypokalemia. Okay, so you can use succinylcholium. You can anticipate slightly long duration because of decrease in pseudocholinesterase. Okay, but tell me one thing: what about the volume of distribution of different drugs changed? So what will have that effect? Because there is more fluid, am I right?
So volume of distribution is increased. Loading doses would be increased, but the maintenance we have to give the low doses for maintenance.
Okay, like we always discuss, what will be the induction agent of choice, or what induction agent will be better, or what will be not to be used. There is no specific contraindication. You can use propofol, you can use thiopentone. Okay, propofol metabolism is not significantly disturbed even in liver failure. Okay, thiopentone will have more hangover, but because the clinical effects of these drugs wave off because of how they
Redistribution.
redistribution. Okay, this is an MCQ question usually being asked. So this what about ketamine? Ketamine is metabolized in liver, but again not significant problems. Okay, so you can be given. So what about midazolam?
Sir, better to avoid if a patient having NCAF or having.
So titrated use or avoid. Okay. What about opioids?
So short acting can be.
What will be the best opioid?
Remifentanil.
Okay, so remifentanil will have no problem.
Sir, we have to give the remifentanil in infusion form, na? So
no, that's not actually my question was something else. From where these esterases are produced?
Sir, in blood.
In blood?
In the liver.
In the liver, but it is metabolized in the blood.
But it will not have very significant. Again, because it is it does not have a clinically significant, because it will have the it will be the still the best choice. Okay, remifentanil, but you can use fentanyl. You better avoid morphine. Okay, and long acting. What about pethidine and tramadol?
They should be avoided. They have metabolites accumulation.
Yes, pethidine, and so you will not use it. Tramadol, what will be the problem with tramadol?
Sir, it causes metabolites in the renal and
No,
renal
tramadol has active metabolites or no?
active metabolites, I think so.
No,
Active
I don't
metabolites.
think so. I don't think so. Just confirm it, because pethidine and this one morphine definitely have active metabolites. I'm not sure about tramadol. I think tramadol can be used, if I'm not wrong. Just okay. So this is one thing. Then what about NSAIDs?
That should be avoided, sir.
Avoided.
Because of
Paracetamol.
bleeding. Okay, paracetamol can be given or no?
Sir,
Can
Can be
it be
given
considered?
in a
Avoid
low dose.
patient with severe disease.
Mm,
Can be
In
given, but in
therapeutic doses, there is no harm of paracetamol.
low doses.
paracetamol should be given in low dose. Okay.
Yes.
Or but if it is totally decompensated, then like there is
Then you can give
It should be
paracetamol.
avoided, sir. Avoided, sir.
then it should be, why you can, you see, there is no compelling indication to give, so you can say that it can be given in if it is there is some liver function, but it is better to avoid. I think paracetamol can be. I will again, because it's a diplomatic answer to be given. Paracetamol. What's the problem? Because paracetamol metabolite is dangerous metabolite is actually calm down in the liver. Okay.
Yes, sir. By the yes, sir.
So what else? What else it will do? I think it can be given in low dose. I'm myself confused while telling this. Okay. And
Therapeutic doses are allowed. Paracetamol can be given in therapeutic doses.
therapeutic dose or low dose it should be given. Just confirm it. I think if it is just confirm it. I'm sorry.
Sir,
Sir, it
70
is
kg.
detoxified in the
70
liver, now.
70 milligram per kg, sir.
Glutathione.
Okay.
So glutathione are not there in a cirrhotic liver or a damaged liver. So toxicity is can occur at low dose as well.
No, but the problem, you know why I'm confused? When liver is already damaged, what will you are saving?
Yes, sir.
Yes, Tayyaba.
Yes, sir. This was my answer when you asked when the liver is decompensated, then what is the point to
Yes.
not to give paracetamol?
Actually, because practically, even if I'm using, I use half dose. Usually, if it is, I'm giving 1 gram, I give 500 milligram. Just confirm it because I don't want to give you a wrong answer. I will check it out as well. Okay. So, what about other dexmedetomidine can be given? What about lidocaine?
It should be given
Cautiously.
cautious.
Lidocaine is also metabolized in the liver, so lidocaine dose should also be reduced. Okay, because lidocaine is also metabolized in the liver. And what else? What else?
Bupivacaine also cautiously.
Bupivacaine also.
Inhalational agent, sir.
Among the inhalational agent, which will be the best one? Desflurane. Okay, because it has least metabolism. And what about neostigmine? Neostigmine, I think no problem. Okay, neostigmine has no problem. If I'm not wrong, neostigmine can be given. Okay, so that's how they will be asking you monitoring. Okay, what about fluid management? Which fluid you should be giving?
So colloid are the better choice, and otherwise salt cystic fluid should be given.
Okay,
to avoid.
Like colloids at the time.
Dextrose.
No, just a second. Colloids should be used at the time when you are expecting fluid shifts, especially when you are deflating the abdomen. At that time, it is better to give the volume with the colloids so that it will remain in the circulation for longer time. Okay, because this is one point. The other point, patient can have hypoglycemia, but dextrose should be the go-to fluid.
No, sir.
Dextrose-
This was my point, that dextrose can be given to avoid hypoglycemia, but it will exacerbate cerebral edema as well.
Thank you very much. Okay. So dextrose, remember one thing, that hypotonic patient has hypoosmolarity or hyperosmolarity.
Hypoosmolarity.
Okay, Atik bhai, you got the answer?
Yes, I got the answer, sir.
Okay, so the osmolarity is also already reduced and you want to give a hypoosmolar fluid. So that's not the advisable thing. Okay. Plasma
Then, sir,
light.
how will you tackle with the hypoglycemia?
Hypoglycemia you can monitor and give dextrose. That's not a problem. Okay. But giving a fluid full of dextrose is not the answer.
Sir,
Okay.
no, it should not be as a sole fluid, na? It can only be
Just
given
tell
when
me
there is hypoglycemia.
and what for example, if you want to give, you can give dextrose saline. That will be a better option as compared to pure dextrose water.
Dextrose water. Yes.
Okay. What the best solution in that scenario will be hyposmolar. Nadir, the statement is that in liver patients there is water retention, so there is hypoosmolarity. Okay. And if you are giving dextrose water, that is also hyposmolar, so that will not be a good choice. Okay. So serum osmolarity will decrease and patient will have cerebral edema and patient can go in encephalopathy. So that's the sequence of events. So plasma light is the best solution. Even in the liver transplant patient, we are giving plasma lights. Okay. Because plasma light does not have which thing?
Lactate.
Okay. Because normally lactate is metabolized in the liver, and actually when we do transplant and when the patient liver is picking up, we follow the lactate. If the lactate is going towards the right direction, it means liver has been picked up by the body at that time. Okay. So that's I'm just telling you that liver lactate. So you will not give ringer lactate. Okay. So that's yes, TRP is also that condition. So that was your question. Okay. So fluid management we discussed like aspiration, we discussed difficult airway, it will be there. And a patient can collapse, so you can have arterial line and fluid management and an analgesia. What else? What about tab block? Can you give tab block?
Yes, sir. Why not?
Actually, you can say that tab block is sometimes given by the surgeons when they are coming off laparoscopic. When they are bringing, they can identify the layer and they can give directly. Okay.
Yes, sir.
So this is an acceptable answer. The tab under ultrasound you can give, but again you can reduce the you will not reduce the volume, you will reduce the concentration so that the maximum dose is decreased. Okay. So what else is left? Okay.
Sir, if possible, we can use a neuromuscular monitoring and
Neuromuscular monitoring. Yes. What about muscle relaxant? Again, our dear friend cisatracurium. Okay. So cisatracurium. By the way, cisatracurium is the least available neuromuscular blocker even in Saudi Arabia. Everywhere, rocuronium. Okay. And actually, this is the best neuromuscular blocker. So what else? Yes. What about
we can use atracurium as well, sir, in Pakistan.
Cisatracurium and atracurium, the medicines which are metabolized in the liver will be a better choice. But as Tayyaba said, it is better to have the neuromuscular monitoring. Okay. Vicronium you will not use. It is metabolized in the liver. Okay. Pancronium is metabolized in the liver. Okay. So what aspect?
No, sir. One question.
Yes.
Now coming towards the intraoperative hypotension and the management of intraop hypotension in the presence of pulmonary hypertension in these patients. So what would be the choice of drug? That would be the metaraminol, because I haven't used that, but I have read about it that it can be given in the pulmonary hypertension patients with hypotension. Is it right?
I also haven't used it because I don't think so it is available frequently. It's available in UK somehow. Okay. Why metaraminol is better?
So because of I don't know, I can't remember it exactly. If Dr. Jameel
Don't,
can help, because of the pulmonary.
Tayyiba, don't go in details. So remain simple. You want to ask if there is hypotension, which fluid you would like, which medicine you would like to give?
That can be norepinephrine or phenylephrine, yes. But I was only concerned about this pulmonary hypertension.
Pulmonary hypertension. Okay, so pulmonary hypertension, if they ask you, just tell me one thing, how to manage pulmonary hypertension?
That's with the beta blockers and all. Propanolol.
Milrinone, sir, sildenafil.
Milrinone, okay? Milrinone, nitric oxide, avoidance of the factors which
that increase the pulmonary hypertension. That's the hypoxia, hypercarbia, and acidosis.
Yes.
Sadishan friend should be
best friend. Okay, so this is one thing. Okay, and if you want, because pulmonary hypertension is not the thing actually to be treated. You don't want right heart to fail. You understand? So Milrinone, what will happen with Milrinone? With Milrinone, you have to give norepinephrine. Why?
Because of that hypotensive effect of the
vasodilation.
That is the
Vasodilator.
inodilator. That is inodilator. Yes.
Just a second. One person, Rabia, you said the lead. Take the lead again. Say again. It has vasodilatation effect. Okay.
Yes, sir.
So whenever you are, and these patients already have low SVR. So if you give Milrinone alone, patient will go in severe hypotension. Okay.
Patient can collapse.
So whenever you are giving Milrinone, you will be using this thing. And these patients, if they are going for like elective surgery, they should be treated with the treatment of heart failure. Okay. So that improve the cardiopulmonary reserve before going for any surgery which is urgent. Elective surgeries will not be done in such scenario. Only emergency surgery. In emergency surgery, you have to do the risk stratification. So Tayyiba, it's my advice. Unless they want specifically, they push you to the point of metaraminol, please don't use the name of metaraminol, because metaraminol, the thing is that you have never used it, and it's not a like very common medicine. Okay, so you can stuck up yourself, because sometimes not all examiners are bad, but sometimes some examiners can be irritated. Okay, so try to be very simple. If you have a patient like that, first of all, you will not let the patient go in decompensation. So you will try to anticipate and try to control in the critical steps which you are taking. You should be anticipating and managing accordingly. Okay, if you want to give, you will be giving an infusion. You can give initially with norepinephrine, because when systemic vascular resistance will increase, the blood pressure will improve. Okay, so overall perfusion pressure will be improved, so condition will be improved. Pulmonary hypertension will be problem, especially if there is shunting. Okay, so that will be the thing. And another thing, of course, according to availability, nitric oxide, as we told, Milrinone, prostacyclin. Okay, these are the things which are there to treat pulmonary hypertension, and avoidance of the factors which are creating increase in pulmonary vascular resistance. Okay, so I think that norepinephrine can be given, and there is no problem. Okay, so what else? And okay, now we will be discussing the scenario. Zishan, you will be telling, there is a patient, a known case of end-stage liver disease presented in emergency in frank the vomitus of blood. Okay, so what will you do?
The patient is just presented with hematemesis only.
End-stage liver disease presented with
End-stage liver disease with hematemesis.
Yes.
And
What else you want?
no surgical concern, just emergency management.
Of course, you don't
Right,
ask
sir.
this question to
Okay.
examiner. Okay.
नहीं, वो, I
Don't
thought maybe I missed
no.
some part of your question.
No. In the exam, they will give you a scenario, because this question is frequently asked. Either they go
Yes.
the patient with end stage liver disease for a surgery, or they present it with some acute emergency. So upper GI bleed is the acute emergency related to liver failure. Okay.
Yes, sir.
So what will you do?
Right, sir. Okay, sir. So my approach will be airway breathing and circulation.
Okay.
I will call for help, and I will assess. I will administer oxygen to the patient.
Again, you have said once ABC, then why coming back again oxygen? When you are using the word ABC, Zishan, there and then you say, I will make sure I will put oxygen. I will make sure patient airway is patent. If patient airway is not patent, I will go for definitive airway. Conscious level is not. If patient conscious level is deteriorated or patient is not breathing well, I will try to secure the airway. This make your habit. Okay.
Right, sir.
Prop up oxygen, right. And then what else?
Prop up oxygen.
See the GCS of the patient. In one scenario, you will do head down. What will be that?
Aspiration.
Prevent
Vomiting.
If
the patient is not conscious.
If patient is not conscious, you will maintain the airway. Okay. In that scenario, you will not do prop up. So right. This is just you have to mention in it. What else? Immediately call for help and immediately call the gastroenterology team. Gastroenterology team, and immediately call for blood and blood products.
Blood and blood products.
Then large bore IV cannulas.
Large bore IV cannulas.
Start fluid resuscitation
with colloid and crystalloids immediately before the blood arrives.
Blood arrive. Very good. Then need for.
Then we'll take a short history side by side. The management and
you will use
assessment of the patient.
Resuscitation, management, and evaluation will go side by side.
Evaluation will go side by side, of course. We'll be seeing how much blood he has vomited.
No. How can you evaluate this thing? That will be generated. You are telling the right thing, but actually you cannot judge through vomitus. Okay. So you will be clinically judging the patient. You can take arterial line to see the volume status. Okay. And you will immediately involve the gastroenterology team to have plan for management. What are the different management options in this scenario?
So first of all, medical management, we have to see the coagulation profile.
Zishan, remember one thing. In the table viva, when they are asking you this question, first of all, try to enumerate. Okay.
Right,
if they want to go in detail, they will take you in details rather than creating yourself in a problem coming out of, because when you are starting talking, you don't know where you have to stop. So try to use the word medical management with the medicines like
vasopressin,
medicines like sandostatin and vasopressin. Octreotide and terlipressin.
Atik bhai, 1 minute ko bolne de. Just let him talk, then I will ask you. Okay. What else?
Terlipressin and octreotide.
Okay. What can be the complications with that?
Complications with these? No idea.
Vasopressin analog can cause arrhythmias, hypertension, rebound hypertension. Okay.
Right.
So they have to be given cautiously. They are vasopressin is where vasopressin is used.
Yes, sir. Right.
Okay.
Vasopressin is we won't be using vasopressin here. We'll be using octreotide and the terlipressin.
Yes, but they are actually vasopressin analog, am I right?
Yes, sir. Yes, sir.
Am I right?
Then there are the sir, right.
Okay, so
and,
then what else?
Then there is the endoscopic approach. They can do banding of the
banding. Okay, what else?
Sclerotherapy.
Sclerotherapy and there
balloon
is
tamponade.
One tube. There is one tube. Balloon tamponade with
tube.
Thanks-taken Blackmore tube. When they are asking you, they again repeat. I tell you, you are pass if you have told the first answer first. Okay,
Okay.
this is extra. If you have, in this scenario, they will not fail you if you forget that. They will ask, maybe they can ask you the dose as well, but they will not fail you on dose. Okay, if you forget the dose, you can say you will just start in a small dose and you will gradually build up according to the patient condition and the response.
Right.
Mics, some mics, it will be some mics per kg per hour. Okay, so I'm
So
just
for octreotide, it is 50 mics per hour.
no, I'm just telling
And,
you that if you forget the dose, you will say
Right.
it will be a smart answer that you say that I will just consult the treating team and I will start at the lowest possible dose and I will gradually build up according to the response. Okay.
Yes, sir.
Because that's not your prime responsibility. So if the examiner listen this answer, he will say he is a smart person. Okay.
Yes.
So this will be the management. So bending, don't go in too much details because that's not your domain. Neither you
Okay.
have to do the bending, nor you have to put these things. Your management
Yes.
is to communicate with the other team and let them do and then know what they are doing. You should be knowing what they are doing. Okay.
Yes, yes.
So the volume
Sir,
resuscitation.
isn't there also the role of FFPs in this patient?
Of course, you
FFPs
have to
and
correct you can do immediately if there is, you will arrange the blood and blood products and according to the level of dehydration, you can do, there is availability. You see, because there is machine for stat INR. So you can say that if you have the facility of doing INR, you will immediately do, there is bedside point of care testing, which is available in the parts of the world. So this is one option. Immediately you will get the number and you can treat accordingly. And of course, till the time you don't correct the surgical bleeding, nothing will work actually. You have to stop it with some pressure or some bending or something, some sclerotherapy or whatever. Okay. And at the same time, simultaneously, supporting the hemodynamics. Okay, Atik bhai, are you getting the specific answers? You don't need to go in detail. ABC, monitoring, control,
monitoring and control.
involvement of other teams, and that's it. Okay, Tayyaba, did we miss anything in this scenario?
No, sir, that's perfectly fine.
Okay.
So one thing I should add, I want to add, sir, maybe I missed it. Sir, 2 bore IV cannula, that is very must in this.
Of course, this is mandatory. And when they are telling the circulation, they have to mention immediately start the fluids, and that's it. Dr. Humera, there is nothing to do with MELD score here. Okay, that is for when they are stratifying the patient for liver transplant. That's it. Otherwise, usually we stratify the patient with. Okay, some words about hepatorenal syndrome. What is hepatorenal syndrome?
Sir, in liver end-stage liver disease, when there is basically a release of nitric oxide or endothelial growth factor leading to spastic vasodilatation, which leads to hypoperfusion of the renals, and because of that, there is functional loss of the liver and activation of renin-angiotensin and aldosterone system, and leading to salt and water retention. There are 2 types, type 1 and type 2. Type 1 has poor prognosis, and type 1 can be treated.
Okay, fine.
Better.
Like in absence of any identifiable renal problem, if there is
Yes.
renal involvement in a patient with liver disease, no infection, nothing, and it is precipitated, this is hepatorenal syndrome. Okay.
Yes.
Etiology, exact etiology is not known. Usually, what you do?
Sir, basically we give octreotides, and spastic vasoconstriction can lead to better perfusion of the renals and avoidance of the diuretics and salt restriction. These are the management.
And then transplant, sir,
Yes.
if present.
Yes. Okay, so what about the above question for you?
Excuse me, sir.
Yes.
Excuse me, sir. Can
Yes.
anybody explain in another in a very simple words Hepatoreal syndrome, sir? Again,
You explain, please.
sir, I don't know. That's why I am asking.
No. You know it. Please tell.
Sir, I want from Madam Rabia to repeat it.
No. You have to speak, please. No, Abhiyar, you will not tell. Atik bhai, please tell. Explain whatever you know. Atik bhai, speak out.
I'm asking, sir.
Let me
Yes.
explain again.
Okay.
Sir, there is basically no renal pathology. Primary renal pathology is absent. Renal functions are not, you can say there is no pathology. Due to hypoperfusion of the renals, there is the renal function, they are lost. So basically that occurs because of the spastic vasodilatation or the hypoperfusion of the renals. So two types. Type 1 is has poor prognosis, and type 2 is developed in slow way, and it can be treated. So
As Tayyaba said, that if nothing works, then this one will be done. Liver transplant.
Sir, it was asked in the previous exam that what are the diagnostic criteria of Hepatoreal syndrome. Because of this, so many candidates have been failed.
No, you know what will be the answer? You tell me. If you are trying to reproduce the criteria of 10 words written in article, I guarantee you cannot reproduce. I can bet on it. You will say that there is renal failure. Listen,
Okay.
Atik bhai, listen. There is renal failure without any primary disease, without any shock, without any infection, without having use of nephrotoxic drugs, and it occurs in a patient which has established liver disease. Okay, if you tell up till that, I guarantee you they will not fail you. Nobody fail on one specific thing. Remember one thing. Okay, and then tell me one thing at the end. What is the result? What is usually is the result of renal failure? What happens? Atik bhai?
You are asking me, sir?
Yes, of course I'm asking you. You have an exam, I think.
Yes, okay, sir. You were asking me, sir. I couldn't understand your question, sir. Can you repeat it again?
Listen, you told me that they asked the question, what is the diagnostic criteria of hepatorenal syndrome, and they fail the patient, they fail the candidates. Okay, so that's what I'm telling you, that if you just tell that it's a renal failure in a patient with known diagnosed liver disease, in absence of any primary renal disease, in absence of any nephrotoxic drugs being used, any infection, only a diagnosed patient of liver disease, and now there is renal failure without no other obvious reason. Okay, and whenever there is renal failure, what will happen? What will be the indices?
Sir, there may be urinary sodium may be less, and there may be, sir.
Listen. Whenever there is renal failure, is it the first thing to tell is sodium?
There may be, sir. No, sir. It is not the creatinine. It is the creatinine, sir, ratio.
No, forget about creatinine as well.
Then it is the
unless very specific hypervolemic or hypervolemic this one natriuretic state of renal failure. Usually, what is the first sign of renal failure? Decreased urine output. Am I right?
Yes, sir.
So why are you jumping to sodium before telling urine output?
It's decrease in renal blood flow or decrease in renal output, sir.
Okay, so there will be renal failure. Renal failure will be established. Atik bhai, just try to make yourself simple. They will not fail you if you tell this thing I can write on the paper. Okay, there is no obvious reason, and then there is failure. When failure occur, what happens? So you can tell whatever indices are there in the failure, the same indices. There is no special thing. Only the problem is that differentiation in the diagnosis. Usually it's very hard. This is actually theoretical concept, because usually it will be very difficult to differentiate that what was the reason for renal failure. So unless until prove otherwise, they will say it hepatorenal syndrome. Okay. So Tayyaba, what is hepatopulmonary syndrome?
So sir,
Atik bhai, now you
basically,
understand? Now you understand or
Yes,
not?
Yeah, I totally understand now.
So if they will ask you hepatorenal syndrome, you will not utter even a single word unless they slap you or twist your neck, tell something else. Say, I have read this thing. I don't know more than that. Okay, and I
Okay.
guarantee you they cannot fail you if you tell this.
Okay, sir.
Okay. Yes, Tayyaba, what is hepatopulmonary syndrome?
So sir, basically this is a triad of three things. We have, first of all, we will be having a liver end-stage liver disease. Then there would be the pulmonary vascular dilatation, which results in the intrapulmonary shunting. This results in the impaired gas exchange and then increase in the AA gradient. Basically, you can say that this is the right to left shunting that of the blood, resulting in hypoxemia. And this hypoxemia even don't respond to increase in FiO2, because this is the absolute shunt. So some of the signs and symptoms which we can see in the hepatopulmonary syndrome are orthodoxia. Orthodoxia is a condition in which patient desaturates while sitting, and then patient get relieved while lying. This is opposite to the normal.
Why it happened?
Because of this pulmonary, I don't know why this happened.
Because of
the
shunting.
Because of intrapulmonary shunting and decreased blood flow.
Mismatch, AA gradient and low PO2.
No, what happens when he
When he
lie
lie
down?
flat, what happens and what happened? Because
it decrease FRC, sir.
Then
Okay.
oh, no.
So
Then what?
the exact mechanism, what will be the reason? Nobody knows.
It's an intrapulmonary vascular dilatation, sir. It is intrapulmonary vascular dilatation that causing.
You know what is the question? This everyone knows. There is AA gradient shunting. So what happens when the patient lie flat? Why the hypoxia is improved?
Might be shunting.
No, sorry. When the patient is sitting, why there is hypoxia? And when the patient lie flat, this hypoxia is decreased. Why?
Might be this is because of this right to left shunt, which gets better when he lies down.
I don't know exactly the reason, actually, frankly speaking. But before you go to exam, I think these are some tricky things which they can ask you in long case. So be ready for it. Okay. I don't have very good idea about it, so I apologize for that. Okay. So this thing need to be corrected. Okay, just try to find this answer, because you are right that when they are sitting in upright, there is increase in shunting. Maybe that can be the reason for deoxia. Okay. So with this deoxia, how much is the respiratory difficulty? I'm not sure, because respiratory difficulty is, I think, something else, and decreased oxygen saturation is something else. There is a little bit of difference. Okay, because otherwise what will happen? Forget about this orthodeoxia. When there is massive ascites, what will happen?
When the patient sits up, he becomes comfortable, and then when he lies down, he becomes stiff.
Yes. So I think
this is normal.
Yes, this is normal phenomena, because just like pregnancy, So whatever occurs in pregnancy, similar to that will be occurring in the ascites. FRC will be reduced, and there are chances of patient having dyspnea. Okay, work of breathing is increasing. So what happened specifically? I think if you don't find a very appropriate answer, but you can say that shunting will be increased when the patient is upright. So that will be causing decrease.
More hypoxia and
Yes.
more decrease desaturation.
I think these two, because I have never seen it. I have
Sir,
never seen in
can
my
I
career.
say something?
Yes, Rabia.
What I am thinking is that when since there is massive ascites over there, and it caused the diaphragm to move upward and leading to atelectasis, decrease in FRC. When the patient lies down, that effect is a bit removed, and so the oxygenation gets better, and maybe that would be the reason they.
Rabia, you are
No,
telling
no, if this
absolutely
happens,
opposite.
no, yes,
I
this
think
is not because of ascites.
I think listen, we will leave this query with this only word, that this is not happening in all the patients. Number one, usual finding will be because of the pressure effects of ascites. In some patients, when it is where is too much shunting, there will be orthodeoxia when the patient is sitting, and because of increase in shunting. That's, I think, the simplest of the explanation you can tell. Okay.
Yes, sir, that is.
Because this is opposite to what is occurring, and actually this is one of the reason for liver transplantation. If this is very
I
severe,
was thinking that ascites is adding up into the AA gradient as
Mhm.
well. So isn't that when the patient sits up?
No, actually this is where we are confused, totally confused, and all audience will also be confused who will be listening to us. Okay, so I think it is better we move on and finish our discussion. And some of the points, I think we have covered almost everything. Some of the cramming things, you know about this child score, you should be knowing. Nadir has mentioned that they have asked in MCPS about liver failure and what are the indications for liver transplant. I don't think so. This is only just to tease them. MCPS or even FCPS, this cannot be the reason for failure. Okay. Yes, you can say there is model for end stage liver disease, which they use to calculate the prognosis of patients who are going for liver transplant. And even they decide that there is King's College criteria for liver transplant because of paracetamol poisoning. Okay. And
So, liver transplant is
Yes,
asked
sir.
in CPS
King's College
questions.
criteria is both for with the paracetamol overdose and also without the paracetamol toxicity. These are the two same criteria.
this is for acute. This is for acute liver failure. Okay.
Yes, sir, for acute.
And model for end stage liver disease is for chronic renal failure. Okay.
Yes, sir.
And what else? And in the start, Dr. Atik mentioned it, and we missed it out, was cautions related to universal precautions and the disease, infectious disease transmission. Okay, because this patient can have viral hepatitis. What are the other common causes of liver failure? This one, idiopathic causes and congenital anomalies. Okay, and in adults, alcohol, Wilson's disease, hemochromatosis, some other problems, primary biliary sclerosis or something like that. Okay, so paracetamol poisoning. Okay, so they will be asking you these questions, and we have almost discussed majority of the common aspects, starting from the clinical anesthesia conduct. What will be the role of regional anesthesia in patient with liver disease? You better avoid unless there is compelling indication. Don't go for central neuralaxial. Okay, I don't think so. There will be any compelling indication to give spinal or epidural in patients with liver. I don't give spinals in patient with liver disease or renal disease. At least in practical purpose, there is no indication. If you have any doubt why you should be giving general anesthesia and risk stratification, avoidance of the drugs which are causing any decompensation. That's it. That's very easy. But if you manage to have a hematoma, you cannot defend it. Okay. So I think these are the majority aspects we have covered. Post-operative ICU care will be there. And again, before finishing, optimization with betterment in the Child-Pugh score, correction of coagulopathy, precipitation, avoidance of the factors which can precipitate this one encephalopathy. Okay, avoidance of the drugs which have active metabolites, risk of aspiration, monitor like goal-directed fluid therapy in the way that you anticipate, especially when they are deflating the abdomen. That will be a critical step. Electrolyte, fluid, acid-base balance, use of the fluids which does not have a significant amount of lactate or hypoosmolar fluid, anticipation related to hypoglycemia. Okay, I think that will be enough for a practical scenario which they ask. Liver patients, regional anesthesia, risk versus benefit. Try to avoid unless there is compelling indication. If there is any scenario in which you have corrected the coagulopathy and there is more benefits than risk, then you can give ultrasound guided blocks. But don't go unless they push you. GA with risk stratification is easier to defend rather than going for spinal and epidural with a one-dimensional vision related to only ejection fraction or something like that. Okay, you can still control the stress response by using some medications, but when you have given spinal or epidural, you cannot control anything. Okay, because the result will not come immediately. And if you are comparing between spinal and epidural, spinal will be better for safety related to a hematoma, and epidural will be better with relation to hemodynamic response. I think that's more than enough which they can ask you. Okay, so altered drug metabolism, altered protein binding, volume of distribution, that's they will be, no avoidance of intramuscular injections, careful taking of IV lines. Okay, what else, Arabia, what were you saying?
So I was saying that in this patient, the intraoperative goals would be avoidance of hypoxia, hypovolemia, hypertension, hypotension, and also preservation of the further deterioration of the liver functions, and also because of altered pharmacology, the reduction of the drug doses and adjustment of the doses and fluids, and universal precaution, of course.
Yes, Atik bhai, happy?
Happy, sir. Sir, one thing more, sir. Sorry, sir. Sir, we need. They asked me about the needle stick injury, sir. Can we do it tomorrow along with the liver
needle stick injury? We will do later this month, because 1 or 2 days are left for the candidates for MCPS Viva. I have tried Zishan. No, I know. I will, Zishan, I think we have covered majority of the topics. Some of the topics which I couldn't cover, you can find it in the recordings. So do prepare pregnant patient, pediatric patient, elderly patient, obese patient, smoker, alcoholic, then position related problems. Then we discuss about liver failure and renal failure in last 2 days. This will be asked. Elderly patient, usually scenario either with the fracture or with the TURP or any acute abdominal condition, they ask. Regional anesthesia with reference to liver disease, with reference to renal disease, with reference to respiratory disease, with reference to cardiac disease. Okay, and where to give, what to give, when to give, risk versus benefit. These are the words which you can use. Acute complications, all the complication you should be having at your tips. Okay, and we can discuss some needle stick also. We can discuss universal precautions and needle stick. I will try to cover in the next few days. Okay, thank you very much, all of you. Okay, and before we finish, Meher Ali, I would like you to speak out. I'm sorry I couldn't pick you. you at least all of you are requested. If anyone wants to add anything, please raise the hand. Okay. Sometimes I'm trying to help everyone. Okay. And if something is still not up to the mark, I'm sorry for that. I try to cover as much as possible. Okay. So rest of the recordings, I'm thankful to Dr. Emika Onaya from which country you are, Emika? Dr. Emika Onaya? Oh.
Can you hear me now?
Yes, I can hear you. Which country do you belong?
Yes, I'm currently in Saudi Arabia.
You are currently in Saudi Arabia. Which part of Saudi Arabia?
Tabuk.
Tabuk, but you are from?
I'm from Nigeria.
Nigeria. Okay. So
Yes,
welcome on board, and we are really thankful. As Pakistani people, we are thankful to giving us honor to join us. Okay, and
thank you very much, sir.
We hope I will one day come to Nigeria and dance with you. Okay.
That would be nice, sir.
Okay, everybody. Bye bye. See you tomorrow. We will. I will have a session most probably at 3 p.m. because I have weekend tomorrow and I will be available. So I will take one session at 3 p.m. So all MCPS and all Viva candidates and anyone else, all of you are welcome. Okay.
So what will be the topic tomorrow, sir, at 3 p.m., sir?
Let me think, and I will send. Okay.
Okay, so that we should study it and it would be more purposeful.
Atiq bhai, you are on the state. You, Rabia, Tayyaba, you are on the state, and at which actually you should not be told any topic. Okay. Because you should be retrospective. Now immediately you should open the book, and whatever thing which we have missed or we have done some mistake, you should cover it rather than preparing, because if you read it and then answer, it's not something special. Okay. Try to be retrospective, try to practice, expose yourself, try to answer, and if you are lag behind, you cover it. I hope in last 2 days I have told you, try to integrate the effects into the clinical management. That way you will not forget. Okay.
Okay, sir. Okay. Thank you, sir.
Okay, everyone. Bye bye. 3 p.m. See you 3 p.m. tomorrow, Pakistan time, and 1 p.m. Saudi time. Thank you.